The following podcast is part of a certified educational activity titled Unpacking the Latest Evidence on Biomarkers and ATTs in the Diagnosis and Management of Alzheimer's Disease, Breaking Updates from CTAD 2025. Access the entire activity and complete the post-test at peerview.com/KPN 860. Downloadable slides are also available.
Hi, I'm Gil Rabinovich from the University of California, San Francisco, and it's my pleasure today to provide an update from the Clinical Trials in Alzheimer's Disease 2025 meeting, providing some of the latest evidence regarding the use of biomarkers and amyloid-targeted therapies in the diagnosis and management of Alzheimer's disease. So the past few years have seen a lot of great progress in early detection and treatment of Alzheimer's disease, but there are still many gaps that persist in clinical practice. We know that the disease is underdiagnosed, particularly in the earliest clinical stages, when amyloid targeting therapies, for example, may be most efficacious. Even though there's been great progress in the development of diagnostic biomarkers, we know that these are still underutilized in the clinical setting, and the emergence of highly accurate blood-based biomarkers that can, in some instances, replace or precede CSF or PET imaging represents an incredible advance that will, I think, greatly democratize access to biomarkers in the clinical setting. And then finally, even though we have very good data from well-run phase 3 randomized controlled trials, we still need to understand more about the longitudinal evidence around efficacy and safety of the amyloid targeting antibodies, the new class of therapies. And so in this program, we will review some of the latest data from the CTAD conference to address some of these gaps. I'll provide data from two studies that utilize long-term extension data from the original phase 3 studies to try to understand the continued benefits of amyloid-targeted therapies. Um, we will evaluate how early treatment may increase the clinical benefits that patients are deriving from these treatments. We'll review the latest data on blood biomarkers, which remain highly promising for the diagnosis of AD, but still caution is warranted as these roll out in clinical translation. And finally, I'll provide some real world data around the selection of appropriate patients and monitoring of safety and cognitive outcomes in people who are receiving treatment in the clinical setting. And so, without further ado, we'll begin with the first study. This study really looked at some very key questions around whether clinical benefits from amyloid targeted therapies continue to accrue over time, even when the active treatment phase is stopped, and whether there is an advantage in starting these treatments at an early clinical stage. And so this abstract was titled Donanemab in Early Symptomatic Alzheimer's Disease, Additional Insights from the TRAILBLAZER-ALZ 2 Long-Term Extension. So this study looked at data from people who were receiving active drug as part of the LTE period. And in order to have a control group of individuals, of course, the placebo-controlled part of the study is over. And so the investigators in this abstract utilized data from the Alzheimer's Disease Neuroimaging Initiative to look at progression in the Clinical Dementia Rating Sum of Boxes, or CDR-SB. They used weighted controls that were similar to the placebo-controlled group in the randomized trial. And what you see on this graph is that the selected ADNI participants match nearly identically in terms of their disease progression to the people that were in the placebo-controlled arm of the phase 3 study. What you're looking at now on the left are changes over time on the x-axis in the CDR sum of boxes, and the red line indicates participants who were included in the phase 3 study and completed their active treatment after 52 weeks because their amyloid PET scan had transitioned from being positive to negative. So these individuals, for the last 6 months of the trial, were actually switched over from active treatment to placebo. And on the blue line, you can see changes in the ADNI control cohort. So what you can see is that at 12 months, there was a benefit, of course, to the treatment group, and that benefit continued to grow at 18 months, even though individuals had completed their active treatment. The new data in this abstract showed that as we looked at continued changes in the CDR sum of boxes on that red line in the long term extension, now extending out to 36 months, you can actually see that difference in the CDR sum of boxes continue to grow from a point estimate of zero point 0.6 at 12 months now to 1.3 absolute difference in the CDR-SB. On the right, you see changes in the ADNI group in blue compared to all study participants in the phase 3 long-term extension. And you can see that the effect size for those who terminated their treatment after 1 year is nearly identical to those who continued treatment throughout the study. And so, what we learned from this study is that people with early symptomatic Alzheimer's disease that met the donanemab treatment completion criteria in terms of clearing amyloid on PET scans at 52 weeks continued to sustain clinical benefits. The clinical efficacy continued to grow, even though the active treatment was over after 52 weeks. What we didn't review is that these individuals, when studied with PET scans over time, remained amyloid negative at 3 years. And so I think these data provide additional evidence that treating individuals with donanemab until the PET scan is negative and then stopping treatment, these individuals continue to derive benefit over time from that active treatment phase. The next study looked at data from the lecanemab open label extension and asked really very similar questions about sustained clinical benefits over time. Remember in lecanemab that individuals in the long-term extension individuals were treated for 18 months with the active treatment, regardless of their amyloid PET status. And then they received maintenance treatment with lecanemab with infusions every month thereafter. In this trial, really, data from the long term extension was modeled to try to understand what the benefit of continued treatment would be up to 10 years out. And so, again, this study utilized data from the open label extension to estimate disease progression over potentially 10 years and looked at individuals that started with a lower amyloid burden defined as 60 centiloids to see if those individuals who were treated earlier in the biological progression of the disease sustained even greater benefit. Again, ADNI was used as a control cohort to estimate progression in the absence of treatment. To help with the modeling, data were actually utilized from 16 other trials of amyloid targeted therapies, ranging a variety of different antibodies. And the models controlled for the severity of Alzheimer's treatment and basic demographics. And so on the left, what you see on the x axis is years since dementia diagnosis, and on the y axis is change in the CDR sum of boxes. The top line represents the estimated progression of the disease in the untreated ADNI cohort. And the very bottom curve that you see, the lower line there on the bottom curve represents the modeled progression rate for people who continued to be treated with lecanemab. And so the estimate in the entire population was that at 10 years, there was approximately 25 less disease progression in the treated arm compared to the control arm. And on the right graph, you can see the same graph, but now looking only at individuals who started at lower than 60 centiloids. And you can see that those individuals derived even greater clinical benefit according to this model, with 44% less disease progression over 10 years. This graph looks at transitions in disease state, looking at time spent in the mild cognitive impairment or MCI stage, the mild dementia stage, until conversion to the moderate dementia stage, which is a stopping criteria for treatment with lecanemab. So on the top, you can see that individuals spend an average of 7.2 years in the MCI phase and 2.9 years in the mild dementia stage. People who are treated with lecanemab ongoing, you can see that their durations in these earlier symptomatic stages are longer, with an estimated 3.5 years saved with continued treatment. And now on the bottom line, you can see the modeled effects in individuals who started at less than 60 centiloids. And you can see that these individuals save an estimated 8.3 years with continued treatment. And so, what we learned from this study is that treatment with lecanemab leads to a time savings at the 10-year cutoff. This was estimated to be between 2.5 to 4.4 years that individuals can stay in that early symptomatic stage for much longer, avoid that moderate dementia stage where they're requiring assistance with some basic activities of daily living with continued lecanemab treatment. Now, take these data with a grain of salt. These are model data. For both studies, the ADNI group was used as a control, so this doesn't entirely simulate a double-blinded, placebo-controlled randomized trial, but these are the kind of data that are done after a definitive trial to try to understand longer-term effects of the disease, and the results of both these studies is very encouraging. So, who is being treated in the real world with amyloid targeting therapies? What are the characteristics of these individuals? What are the clinical outcomes that we're seeing in these individuals, and what are the safety profiles? In this series of talks, we saw a first look from the Alzheimer's Network, ALZ-NET, which is a national registry of sites that are providing amyloid targeting therapies as part of clinical care. This is a nationwide registry following individuals longitudinally and looking at cognitive outcomes and safety outcomes. This is known as ALZ-NET, run by the Alzheimer's Association and American College of Radiology. These are the characteristics of people who are enrolled in ALZ-NET and are receiving amyloid targeting therapies. You can see the majority are receiving lecanemab, with a smaller proportion receiving the more newly approved and available donanemab. That's the middle column. And on the right column, you can see the collective demographic data of all individuals receiving therapy. A few people are receiving aducanumab as well. You can see the median age of individuals receiving treatment in ALZ-NET is about 75. The median age at the onset of cognitive symptoms is 71. And so there's still a long delay of 4 years between when individuals first experience cognitive symptoms and when we are initiating therapy. And we all know that time is brain. And so I think we really need to figure out ways to shorten that time span, enable earlier detection and diagnosis. And as we saw in the previous trials, there may be even greater benefit the earlier we start treatment. So that, I think, is a real lesson from this talk, is that there's more work to be done to enable and facilitate an earlier diagnosis. Individuals receiving treatment in ALZ-NET, there's a preponderance of females, 54.4%. 85.5% self-identify as white or European. So there's limited diversity. This is not really capturing some traditionally underrepresented groups, suggesting there are potentially disparities in prescription or access of these drugs. This is, in general, a highly educated population, with 43.7% having at least some college education and even 26% having advanced degrees. So, overall, this population looks a little more like a clinical trial population than a population based estimate of the demographics of people with dementia in terms of a younger age, limited diversity, and relatively high educational attainment. 97.6% preferred English as their first language. And in terms of insurance, you can see there are a variety of different insurers reimbursing the cost of these treatments. Most individuals in ALZ-NET are on traditional Medicare fee-for-service, 57.6%. There's also 23.7% on the Medicare Advantage plan, 17% with another insurance status, and only 1.7% receiving Medicaid. On the right pie chart, you can see that in the real world, people are appropriately treating the early clinical stages of Alzheimer's disease, with 63.7% of treated individuals at the MCI stage, 34.8% at the mild dementia stage, and only 1.5% at a more advanced stage of moderate dementia. And so this is very appropriate according to both the FDA label and published appropriate use recommendations. These drugs are really intended for MCI and mild dementia, and that does appear, in fact, to be what's happening in at least in the ALZ-NET real-world sites. The pie chart on the left shows the breakdown of ApoE genotypes. To make things a little easier, all E4 carriers are shown in different shades of purple. Overall, just over 60% of people in ALZ-NET carry one or more ApoE4 alleles, as you would expect. The rate of E4 homozygotes is 8.5%, which is about half the proportion that we see in the clinical trials, suggesting that there may be some hesitancy around treating ApoE4 homozygotes. We know that these individuals are at the highest risk of having amyloid related imaging abnormalities or ARIA, with a box label specifically for this population warning about ARIA risk. And so it does look like in the real world, there are fewer of these people being treated than you would expect in the population. 7.8% did not have ApoE genotyping conducted. So, great news that over 92% are having ApoE testing, but still room potentially to improve because ApoE genotyping is just a critical part of counseling patients about potential risks associated with these therapies. The graph on the right now shows the qualifying biomarker that's used to establish amyloid pathology in people who are started treatment during their enrollment in ALZ-NET. Amyloid PET was the most frequently used biomarker at 51%, followed by CSF at 30% and plasma at 22%. About 20% of all individuals had multiple biomarkers tested, and 18% did not report any amyloid biomarker. It a little unclear if this is just missing data because an amyloid biomarker is needed in order to spark reimbursement of these treatments and establish the presence of amyloid pathology. So, need to dig into that a little bit deeper. What about cognitive and safety outcomes? Um, in 608 patients that are currently receiving treatment for up to 18 months, the median change on the MMSE at 6 and 12 months was zero in the MCI stage and between -1 to -2 in the dementia stage. This suggests relative stability of cognitive status during the course of treatment. Changes in the functional status as measured by the FAQ, the median change is also around zero at 6 and 12 months. So these are encouraging. Again, no control group to compare to, but suggest relative stability of cognitive status in individuals receiving these therapies. What about ARIA rates? Right now, those are at 12.2%. Here on the pie chart, you can see the breakdown also between ARIA E, ARIA H with superficial siderosis, and ARIA H in terms of microhemorrhages. These rates are lower than the rates reported in the clinical trials. Time will tell if this number stabilizes or grows over time, but very encouraging first look at the safety profiles of people receiving amyloid targeting therapies in real world care. The graph on the left shows the rates of ARIA by APO, or the counts of ARIA, I should say, by APOE4 status. So, not surprisingly, we see higher rates of both ARIA E and ARIA H in APOE4 carriers. This is what we would expect from the clinical trials. So, what happens to individuals who have an ARIA event and then later continue treatment? Well, what we've learned so far in ALZ-NET is that in these individuals, four radiologically severe ARIA events occurred in three individuals who were taking lecanemab and continued treatment after their first ARIA event. Thus far, there haven't been any radiologically severe ARIA events in individuals taking donanemab who continue to receive treatment. But remember that donanemab treatment is still a little bit behind in terms of overall numbers and follow up in ALZ-NET because the drug was approved about a year later. ALZ-NET reported that there was one macrohemorrhage or intracranial hemorrhage greater than 1 centimeter in diameter occurring for participants taking each drug, lecanemab and donanemab, who continued to receive treatment after their first ARIA event. So these data just highlight the importance of being very thoughtful about whether to continue treatment when individuals have already had an ARIA event. The appropriate use recommendations, in fact, recommend stopping treatment when individuals have had two ARIA events during the course of their treatment, and that may help prevent some more severe cases. Fortunately, there have been no ARIA related participant deaths so far in ALZ-NET, so overall, still early days in terms of clinical follow up of these individuals in the real world, but the safety profile looks very encouraging, both in terms of the overall rates of ARIA and in terms of the prevalence of severe ARIA events. In general, the ALZ-NET population, the early adopters of amyloid targeting therapies in the real world, seem to resemble those of clinical trial participants in terms of having a relatively young age, high education, limited racial and ethnic diversity, what I haven't shown you, but lower rates of medical comorbidities and use of antithrombotic medications, a lower frequency of E4 homozygotes. Participants are appropriately being treated at the early clinical stage of MCI or mild dementia, and compliance with biomarker and ApoE testing is very high, but not yet perfect. So potentially still room to improve standard of care. And on longitudinal assessment, we see stable cognitive and functional outcomes over 12 months and very rare severe ARIA outcomes and overall encouraging ARIA rates in terms of safety of these drugs. Another very important advance in the field has been the emergence of blood-based biomarkers. So there were two studies presented at CTAD that looked at the performance of the two FDA-cleared blood biomarkers in different clinical populations. The first study we looked at the FDA-cleared Lumipulse assay, which is a ratio of phosphorylated tau 217 and beta amyloid 142 for the detection of amyloid pathology. This is an assay that's run on the Lumipulse platform. It was the first FDA-cleared blood-based biomarker for the detection of AD pathology in individuals aged 50 years and older. Here you see the data that led to FDA clearance, data from 4 different cohorts with different degrees of cognitive impairment. The readout of this assay is a ratio of p-tau 217 to A-beta 42, and there are 2 thresholds: a negative threshold, below which an individual is considered amyloid negative, a positive threshold, above which an individual is considered amyloid positive, and an indeterminate range in between the 2 thresholds where additional biomarker testing is recommended. And here you see that the sensitivity, specificity, positive and negative predictive values of these thresholds in these initial cohorts were north of 90%. This study looked at their performance in 2 additional cohorts: the Mayo Clinic, subspecialty clinic, which was enriched for people with cognitive impairment who were being evaluated for amyloid targeting therapies, and the Wisconsin Registry for Alzheimer's Prevention and Wisconsin ADRC, which is enriched for individuals who are at genetic risk for Alzheimer's disease. And what you see here, first on the left, are the results of the FDA-cleared p-tau to A-beta 42 ratio, where A designates amyloid positivity status based on PET or CSF. So how did the blood biomarker do compared to the more established CSF or PET readouts? In the Mayo Clinic cohort, you can see that all 177 individuals who were positive on PET or CSF were also positive on the blood biomarker. However, 30 of the individuals who were negative on PET or CSF were actually considered positive on the blood test. Another 36 were intermediate, and only 9 were designated as negative by the blood test. So this resulted in a sensitivity of 100%, but a specificity of only 23%. These thresholds performed better in the Wisconsin cohorts with a sensitivity of 99% and a specificity of 85%. The data are compared to the Mayo Clinic in-house p-tau 217 assay alone, so not the ratio, and you can see the specificity was higher in the Mayo Clinic cohort using their p-tau 217 alone compared to the FDA-approved test. So is this a problem with the test, or is it a problem with the thresholds? Well, a subsequent analysis really suggests that it's a problem with the thresholds. This is an area under the curve using a ROC analysis that showed that the overall area under the curve for the test was 0.96. And in fact, when they adjusted their thresholds, they were able to obtain much better specificity, still maintaining sensitivity in both the Mayo and Wisconsin cohorts, and the performance in terms of negative and positive predictive value was much better. So this just suggested that the Mayo Clinic cohort required a recalibration of thresholds in order to accurately designate individuals as amyloid positive or amyloid negative. So I think the take home from this study is that the published performance of tests may not generalize to every population, and we really need independent real world validation, even for FDA cleared assays. While the assay performed very well, the thresholds require further validation. And as we start to use these drugs in clinical practice, it's going to be very important to obtain confirmatory biomarkers when the tests are positive, especially in individuals who are being considered for anti amyloid therapies. Another biomarker that's FDA cleared is the Roche Alexis p-tau 181 assay. This assay has actually been cleared to be used in individuals who have cognitive complaints who are seen in the primary care setting, not in the specialty setting. And this assay was really calibrated to rule out Alzheimer's disease in these individuals. So, a negative test has high accuracy in predicting a negative, either PET or CSF study, very useful for ruling out Alzheimer's disease or high negative predictive value. However, positive tests, especially in the primary care setting, would require further validation with an additional biomarker. So, that's how the test was designed. How did it perform in a real world setting? And so in this study, they looked at the established FDA cleared cutoff of 0.722 picograms per milliliter in a primary care uh, population. And what they found, though, is that the prevalence of amyloid PET positivity in this population was relatively low, it was only 13%. And they found that the test performed very well in terms of its negative predictive value at 97.9%, but the positive predictive value was only 22.4%. In other words, only 22% of individuals who were above the threshold on the blood test actually had a positive PET scan. And so, what we conclude from this is that this test has high negative predictive value, but low positive predictive value for amyloid pathology in people who have signs, symptoms, or complaints of cognitive decline. And again, a negative test can be used to rule out Alzheimer's pathology, but a positive test really needs to be followed up with a confirmatory biomarker. The final study that I'll cover represents top-line results from two highly anticipated phase 3 double-blinded randomized controlled trials called EVOKE and EVOKE Plus, which tested semaglutide, the GLP-1 agonist, in individuals with early-stage symptomatic Alzheimer's disease. These were two very similarly designed studies, recruiting individuals at early clinical stages of Alzheimer's disease and randomizing them to get either oral semaglutide or placebo. The EVOKE Plus had more lenient inclusion criteria around vascular disease. So actually, what recruited individuals who had a higher vascular burden or were at higher vascular risk. There are a lot of data to suggest that this class of drugs, the use of this class of drugs, is associated with a lower risk of dementia, and also some basic animal model studies suggesting that these drugs may have direct effects on different elements of Alzheimer's pathophysiology, including amyloid, tau, and neuroinflammation. So here are the demographics for individuals in EVOKE and EVOKE Plus. In general, this was a pretty typical early clinical AD trial with a mean age of 72 altogether, a little bit of a female preponderance, actually good representation of of Asian, and Hispanic or Latino individuals. And the average, most people, 72%, had a global clinical dementia rating score of 0.5, a mean MMSE of 24. So, an early symptomatic AD population. These graphs show results of the primary outcome, which was change in the CDR sum of boxes in EVOKE and EVOKE Plus. And you can see in both trials, there was no significant benefit to drug over placebo, with nearly superimposed lines showing progression on the CDR sum of boxes between active treatment and placebo. Very similar findings for a secondary outcome, changes in the ADCS, ADL, MCI score. And there was also no benefit in delaying time to progression to dementia in individuals with MCI, as shown on the graph on the right, and really no benefit on any of the other secondary or exploratory clinical outcomes. In terms of safety and tolerability of oral semaglutide, these results were very consistent with other studies using this drug for other indications. And so, what can we learn? What did we learn overall at CTAD? Well, we learned from two studies looking at long term extension and using statistical modeling and historical controls that early intervention can be useful and result in greater clinical benefits in individuals who are being treated with amyloid targeting therapies. The Trailblazer-ALZ 2 study showed continued benefits after discontinuation of treatment uh, upon amyloid clearance at 52 weeks, yet benefits were maintained even up to 3 years. The statistical modeling study demonstrated that people who remain in early clinical stages of AD and continue maintenance lecanemab treatment may derive additional benefit, and starting earlier is associated with greater benefit for these individuals as well. From ALZ-NET, we learned that amyloid targeting therapies can be safely and effectively delivered in clinical practice. From the blood biomarker studies, we learned that the Alexis phospho-tau plasma assay had a high negative predictive value and a low positive predictive value in the primary care setting, suggesting, again, negative test is fine for ruling out AD. Positive test should probably be followed up with a confirmatory CSF or PET study. We learned that the Lumipulse p-tau 217 to A-beta 42 ratio um, requires further validation in terms of its threshold, though the test overall still seems to be quite accurate in detecting amyloid pathology, but using the right thresholds is really key. So more work is needed. And unfortunately, from the EVOKE studies, we learned that oral semaglutide did not slow cognitive or functional decline in individuals with early symptomatic AD. So thank you very much for your attention. Hopefully, you'll find these data informative in your clinical practice. And thanks very much for this opportunity.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/KPN860.